May I have your attention, please? Distinguished guests, ladies and gentlemen, morning session of first day of 23rd Pioneer Sergeants Conference is about to begin very soon. May I request all the guests to kindly take your seat, please? Thank you. Request all the guests to kindly take your seat, please. Good morning, all the distinguished guests, professors, ladies and gentlemen. Warmly welcome to today's morning academic session of 23rd Pioneer Sergeants Conference. I am Dr. Aida Che, second year postgraduate student surgery from University of Medicine 2, and this is my senior colleague, Dr. Khaisen Wei, third year postgraduate student surgery from University of Medicine 2. Together, we will be the master of ceremony for this morning session. I would like to announce that the first session will be the plenary session. May I respectfully invite Professor Thein, Professor and Head, Retired Department of Surgery, University of Medicine 1, and he is also the past president of Myanmar Surgical Society, and Professor Thong U, Professor and Head, Retired Department of Surgery, University of Medicine 1, and he is also the past president of Myanmar Surgical Society to take the chair for this plenary session, please.
Good morning, ladies and gentlemen. Welcome to our 23rd Pioneer Surgeons Conference today. This plenary session is the first session of the conference today, and we have two speakers in our session. And the first speaker is Professor Brigadier General Thein. He was Director of the Medical Services, retired, and Director of Medical Service, Ministry of Defense. Well, he was one of my CRGs when I was undergrad medical student in Institute of Medicine 2 at Mangalore. He was also well known as the youngest surgeon from Burma who got the FRCS in Edinburgh many years ago. For many years, he dedicated to surgery, teaching, administration, and writing health articles on and off. Despite his age, he is still active and actively participating in many academic activities. Now, may I invite Professor Brigadier General Thein to deliver a talk on medical ethics in surgery.
Good morning, my chairmen, ladies and gentlemen. I am privileged and honored to have this talk in this glorious surgical conference. The chairman has mentioned a little bit about me, and I want to add a few. That is, I am the graduate of IM1 in 1964, at the top of the list. And I got my fellowship in 1967 in Edinburgh. Since then, I was working as a surgeon, as an administrator, both in the military as well as in the civilian. I was the professor from honorary lecturer to professor in Department of Surgery from 1974 up to 1992. And then I was in the administration department in defense services, and I was working throughout as clinician as well as administrator, and also I wrote a little bit about our medical profession. So this is, I want to say, I'm now 83, 84, and this might be my last lecture, but I'm very eager to give it to the next generation. So what is my aim to deliver this lecture? My aim is to see better generation of surgeons, because this surgery is a noble profession. And then we are proud to be surgeon. And then we want to make our profession better and brighter. So this is my sole reason why I'm giving this lecture. So how am I going to achieve this promotion? I intend by improving awareness of the surgical ethic among us, and by providing lessons from our mistakes, mainly from my own, so that you not do the same like me, and also by encouraging to be mindful of surgical ethics for our noble profession, and also by avoiding medical error with surgical ethic. So before we consider surgical ethic, we should know what surgery is and what is surgery. I think you all know. But my own belief is we are the operating physician. Surgeon is an operating physician. So you must know all the things which the physician know, plus you have the ability to do surgery. So you can consider yourself how important you are. So surgeon is the person who do the surgery. What is surgery? Surgery is the process we are delivering to our patient. So there are different kinds of specialties. So all are included as a surgeon, and they are doing surgery. So the nature of surgery is you go by action rather than knowledge. You must have knowledge, but our main aim is the action. If you cannot do operation, you won't be able to, you will not be called surgeon. You cannot operate by mouth or by thinking. But these are essential. So our main goal is by action, then knowledge. And also, we must explain to the patient surgery hurts before it heals. So the patient comes quite okay with that, supposing with hernia. He has hernia, but no pain, nothing. But we know that this will not be cured by medicine. So we submit him to the surgery, which hurts him. But after that, he was cured of the hernia and then it healed. So this sort of knowledge must be given to the patients. And also, we must understand that the patient's trust to us is with his life. When he is under anesthesia, he cannot say anything more. So before he go to surgery, he must know what he is doing. So the patient trust to us is with life, and we must care for this very seriously. Then this is very important. That is the gross and obvious error. When we do something wrong, medical error, for medicine and the one who are doing with knowledge, it might not be very obvious. But when we do something wrong, it is obvious to everybody. So we must be very careful, because nowadays with private clinics, hospitals, in charging too much, the patient are ready to make complaint about our error. So this shows that we must be very cautious. The next one is the surgeon's sole responsibility to advance and protect the patient. This is our main responsibility. We must do for the patient's safety to cure the patient. This is our own sole responsibility. The patient trust is with us, so we are responsible. Another one is surgery is a teamwork, a responsibility of all the team members. As a surgeon, you cannot do alone. You have to have the team. This everybody know. And then we must just sit down and sleep. We have to do continuous professional development by learning and practicing all the time. So I want to mention Professor J.B. Maxter's teaching. A true surgeon is never fearless. He fears for his patients, for his mistakes, and for his shortcomings. But he never fears for himself or for his reputation. So I always keep this in mind, whatever I do. So we are fear for our patient. So we must care the patient. And we must make him fit for surgery. We must make he recover well. And for this, we have to do everything we need. And also, he is afraid of his mistakes and for his shortcoming. So for these, we have to study all the time. We have to contemplate what we have done so that we will do the same mistake again. But he never fears for himself or for his professional reputation. If he has to do something, if it will save the patient's life, then we have to do it in spite of some rumor or some blame to us. So this is regarding the surgeon and surgery. Now we have to say about ethic. What is ethic? It is a branch of philosophy guiding the principles of what is right or wrong and good or bad in a particular situation for the person and the public in regard to thought, speech, and action. So, ကိုယ်စိတ်ပါဇက်ရောနောက်ပြီးတော့မှလှုပ်ထားအကုန်လုံးမှာကျွန်တော်ဟာနော် principle တွေနဲ့နော်ဘာဖြစ်ဘာလို့မမှားအောင်မယင်းအောင်ကောင်းအောင်မဆိုးအောင်ဒါတွေကိုကျွန်တော်ကသိဖို့လိုတယ်နော် So what is surgical ethic? I read about many books and from the internet also, and my own feeling is that it is a surgeon-patient relation. Surgical ethic is surgeon-patient relationship, and surgeon's responsibility to advance and protect the well-being of the patient by 4 basic pillars. That is autonomy, benefit, no harm, and justice. It concerned with the principles that allowed us to make judgment and decision about what is morally right or wrong, and good or bad for the patient in public in our surgical practice. So, this judgment and decision is very important for surgeon. You all know that there are three different grades of surgeon: good surgeon, better surgeon, and best surgeon. They mainly depends on your judgment and decision. Every good surgeon can operate, but better surgeons know when to operate, and best surgeons know when not to operate as well. But I want to act one thing, that is a perfect surgeon. This is not seen in the books, but my own feeling is, if a surgeon happened to operate, and during operation, he found that if he proceed, he might injure or he might do danger to the patient. In that case, he retreat. He must have the ability and courage to retreat or to reject the surgery before operation. I have met one Chinese American surgeon while I was doing volunteer work in Delaware. He was the team leader, and he discussed with me about one patient with very huge hernia. So hernia is so big, if we push it in, the patient cannot breathe because it was there for about 20 years. He's age 65. And so he said, Dr. Han, I think this patient should not be operated. I said, yes, because he is a surgeon when not to operate. If he operated or we operated, then we won't be able to close the abdomen because abdomen is very small, the hernia sac is so big. So this sort of patient needs very good pre-operative preparation. So this sort of person is I honored and I respected him also. So regarding this, I want to share my knowledge here also. One of my grandnephew, while operating tennis with his father, he slipped and got injury to the knee. They went to the nearby clinic, specialist clinic or hospital, and they took X-ray immediately. And then they said, oh, there was a fracture. He need administration and operation. So they came to me with the X-ray. And when I saw it, there was no deformity and then no injury to bony structures. I said, this might be just an ankle sprain. So they stayed without operation and he was okay in 3 days. So I do not know why the medical officer there suggest or miss the diagnosis, which was very obvious. Similar occurrence occur when a old man had accident with car. He was on the bicycle and he got some back pain. So went to a specialist hospital, and they are the private hospital, I'd say. And they took the X-ray and they said there was a fracture and dislocation. The patient needs surgery and he was admitted. My nephew came to me with the X-ray and I saw it. And with my surgical experience over 50 years, I didn't see any abnormality apart from mild spondylosis. So I said, and they said it will cost about 20 lakhs at least. So the patient couldn't afford. So they get out discharged, and in a week he was okay without surgery. So I was thinking, why these doctors, they did the X-ray and they read it wrongly or purposely, I don't know. Why they make the mistake, they will only know. So this sort of thing, maybe because they are not competent, or they are competent, but maybe they want to get more money by operating on the patient. So these sort of things are the breach of surgical ethic. So I want all of you to bear in mind these things. Then we should see what are the 4 pillars of surgical ethic. They are autonomy, beneficent or benefit, or non-maleficent or no harm, and also justice. So I want just a few words to say this. This is the autonomy is the patient's own decision. Patient came to you because he didn't know it. So it is our responsibility to let know the patient all the information regarding the disease, treatment, diagnosis, treatment, and the outcome. So the patient must have informed, valid consent, which is confidential. You should not tell other people. And for such a consent, the patient must be rationally and conscious. The child cannot give the consent. The mad person cannot give it. So the patient must be rationally, and he must be fully conscious what he is doing, what is listening, and what he understands. And he should know the diagnosis. If we have time, we must explain him why we get this diagnosis. So if they get diagnosis, they will want to know where will be the surgery if the surgery is decided. So if surgery is decided, this will be where and when. I'm showing these pictures where in one district village I operated. This is the operation theater. It is under the ground floor, in the ground floor of the house. And we make with the plastic, and then the operation table is as you see here. Very clearly, it was not an operating table, you see. So with this sort of thing, you should not do it. But I did it. You can consider me as a fool. But the situation there is that village has even no nurse. And when I went there, I intended to do just give him prescription and medicine. But when I was there, I saw that the patients were surgical patients. So they could not go to nearby town because they were very poor. And I know that it's not the place to do, but out of sympathy, I did it. And then I have only 6 doctors accompaniment, no nurse, nothing. But we manage it, and luckily, no complication. But I am showing this to you not to do it. No, I did it because out of necessity. It's not ethical. So here you see, we went that village with a bullock cart. And then the patient want to know if no treatment, what will happen? You must explain to the patient. And if he has to be hospitalized, what is the duration and what the outcome and then the complication. And also now in private hospital and clinic, it is very important to know the cost. This is such a team, and the surgeon must know and have this team. And then, as you see here, there are many qualities which all the members of the surgical team should have. They must be honest, compassionate, and empathetic. And they must be qualified and competent. Qualified means not only they have the degrees and experiences, but they must also have license. I'm telling this because next in next presentation I will say what it is so. And they must be qualified and competent, and then there will be no coercing or persuasion. It must be the patient's own decision. And we have to do in the best interest of the patient, not for money, not for reputation, not for the patient only. And the surgeon must be cordial and polite. If you are very conceited and you deal with the patient rudely, it will be no good, you see. I started about 10 minutes late, so I think this is only 20 minutes only. I am having my watch here. So the one inside came in. So I'm just telling you that I was allowed to present for 30 minutes, and my presentation is still in the mid. And also, surgeon must know your own limit. When you know that this is out of your own limit because of your incompetency or because of lack of facilities or any other reason, then you must not wait. And you must know where and when. So whatever you choose should be for the patient. And then should not be no sepsis, and good ventilation, and then good disposable methods. So the operation theater must have also facilities for emergency, and then all the members must be cooperative and coordinated, and these people must be also healthy. If you have some cold, or if you have flu, or if you are incapable for some reason, then you should not be in the team member. And also, continuous professional development, innovation, and technology are essential for all the surgeons to continue. And then now I ratio surgical checklist. This is very important. And previously we met some medical era where instruments and causes are left in the abdomen or chest. So with surgical checklist, this can be avoided. And also, one thing I want to mention to all you is, please do not take advantage over the patient's ignorance. The patient came to you and they trusted you, so don't intend to cheat. And just like I said, the patient didn't need surgery, but they suggested surgery. And when there was no surgery also, the patient is quite okay. So this sort of thing, we should not do it. And also, when we are dealing with surgery, we must have the critical thinking in all the aspects. And then timely intervention is essential. So, depending on our knowledge, judgment, and surgical, what are the surgical decisions? So, this is my own thinking. And I was doing surgery since I was medical student. And up till now, I'm doing. So my own thinking, I always say it is very unique. But when I see the patient and the patient needs surgery, and I had to consider when I'm going to do it and what am I going to do it. So if so, when we were to think of whether it's urgent or emergency or routine. So whatever it is, if the facilities are available and the patient's condition is safe for surgery, we can do it. But if facilities are not available, what are we going to do? We have to think of the patient. So we have to think transfer to other hospital or other clinic or other town, or we have to maintain the patient's condition by any means, by conservative treatment, or we can also do the optimizing patient's damage control surgery. And if facilities are not available and the patient is very, very urgent, if you do not do anything, the patient might die. In that case, do it if there is consent. If there is no consent, then we cannot do it. So this is my way of thinking for patients. So this is quite important. Beneficent is to do best interest of the patient, prepare for safe surgery, because safe surgery save patients. And then correct diagnosis. If not, diagnosis not correct, your teeth will also be not correct. So there's no right way to do the wrong thing. This also you must bear in mind. And also you have to prepare for possible complications and then be patient with you must be with the patient in time of emergency. And then timely intervention is essential for the benefit of patient. For no harm, non-maleficent, do no harm to patient. This is the teaching since Hippocrates' time. and you have to prepare well for surgery and need timely intervention. You must see that facilities for emergency are available, and you have to follow the surgical checklist. And sometimes you have to repeat the examination. Because this is one case, patient was seen by the senior surgeon, and straight away he said, "This is appendicitis, and I will operate next morning," and prepared. But the patient's guardian happened to be a lady doctor, wife of my friend, and she brought the patient to me on the morning where she will be admitted. But when I saw the patient, the girl was weeping, not because of pain, because she is afraid of surgery. When I examined, there was no signs of acute abdomen. The patient passed motion, passed platters, and no pain, and she is feeling fine. So I said, because the surgeon is senior, and he might have something. So I saw the box, and there was nothing write down, just acute appendicitis, prepare for surgery next morning. So I just wonder, why this surgeon do this sort of thing? Because since we are students, we are taught to have the proper surgical or clinical examination and to write down the findings. Nothing, no investigation. So I asked, to be sure that the patient is okay, please do CP, ultrasound, and X-ray abdomen. If she did everything and it was all right, the patient was all right. And so they didn't go that way, and she was well up till now, about over 1 year. So this is all the thing the patient should repeat. Then avoidance, overconfidence, avoid overconfidence. So this is my own case, you see. No? So I was requested by the radiotherapy department consultant. He was giving treatment to my mother who had chest, lung. And he said, nobody in the hospital help him to get the diagnosis by doing biopsy, open biopsy. When I see it, there was a big, huge mass in the right hypochondrium. So I said, oh, it was quite okay. So I took her to my hospital and I did the operation. I found a huge mass. The liver was perfectly normal. So I was in a dilemma what to do. So when I feel it, it looks like kidney tumor. So before that, I was doing nephrectomy for kidney tumors and for bed iron nephrosis for few cases without any complication. So I said, I might be able to help this patient. She was very poor. So I tried to mobilize the tumor, and I couldn't do it well, but I can do it upper bone, but lower bone, no. So I thought, what could it be? If this is the kidney and pushing the viscera medially, then should not be anything. So I did mobilize. And while mobilizing, I cut first the renal vessels. So I said, how come And still, I said, this is okay. If one side is, the other side is okay. So I mobilized further. And second, this time, I cut the inferior vena cava over the tumor, which is not in the normal position. So at that time, pressure fall, and the anesthetist bind me. So I said, we will stop it. And we stop it. And while operating, the patient cardiac arrest, and we can survive it. And so we send the patient to the post-operative room, and there the patient had 2 attacks of cardiac arrest, one after another, and succumb. So this is my foolishness. No, I don't want any of you to have such a foolish thing. No. So why did I do it? Because maybe I was self-conceited. I did a few nephrectomy and I think I can do it. That's the reason. Then I am not competent enough to see when to retreat. So because of that, at that time I was only 35 or 36. So my experience is quite small, and these are the mistakes I did it in my surgery. So I'm just telling you the mistake I take it not to be followed, but to avoid it. Then we have to think of the gastric. Is no discrimination, may need prioritization with limited facility, and must be transparent, especially in lack of facilities. So you see the next patient. This patient had the neurofibrolipoma back. And he was operated at the age of 14 once in the sub-township hospital. And I saw this patient, and I decided to do it in that hospital. You can see how foolish was I. But if I do not operate, the patient will die with this. He has attempted suicide for 2 times because of this burden. And he cannot even afford to have the transport from his village to that hospital. So, however, I tried to manage it, and I operated. This is assessing the patient and how I did it. You see lots of artificial, because I couldn't have the cautery. All I had is a very dysfunctioning bipolar 1. So however, I did it, and it took about 8 hours. And this is the after the first operation. And this time I said, I'll do it in the facility available hospital, and I did it this second one, no? Sorry. This is after the first surgery. But the second surgery, I did it private hospital at my own expense because they cannot afford it. So after that, there was nothing. He was quite a normal person and doing walk routinely. So I want to give you lessons, you see. So as a student, maybe I did a criminal act. And this caused me a lot of anxiety. At that time, to be frank, I didn't know what ethic is. I was in the fourth year, no, final part one, just beginning after the 1962 coup, you see. After that, I went to the Pegu General Hospital where the superintendent was my teacher, Sayi Ukamauji. And he taught me there. And one day there was no doctors. I was alone at the OPD. And I saw this patient about 30 years old with history of the myocardial, their penis. And he couldn't pass urine well for about a year. So I see that you cannot retract this. Oh, my knowledge, if you cannot retract the foreskin, it is the phimosis. I have seen lots of phimosis being operated by my teachers. I thought I might be able to do it. So I persuaded the operation theater in charge, and I did it under local. And at that time, I couldn't retract the skin, and I was, whatever I did, I was bleeding. So I probe it, and the probe went about 1 centimeter through the opening, which I thought was external meatus. And I said, I thought I should stop. So I stopped it. And but at that time, there was no doctor left. So the patient went back home. And then when the school opened, I returned to medical college. In about 1 month later, the patient came to see me in the hostel. When I saw him, my heart beat very loudly and very rapidly because I think something was wrong and I will be in trouble. But I intend to be okay, and I asked, how are you? He said, oh, very well, sir. Since your operation, I'm okay. So I want to give some present. So he brought the kind. He was to give me at a hospital, but I was in the young homes. So he followed me here. So this is very lucky for me, but I want to see you. I am doing medical error mounting to criminal act because I'm not a doctor yet. I have no license. And then, as yet, I did this operation. So this should not be done. Another one is Thein neurolipoma. I have mentioned it just now. And I was at a daredevil surgeon with limited surgery. And for retroperitoneal tumor, I was self-conceited, over sympathy, no right way to do wrong thing, I should know, and failure to stop it. And lipoma nerve, this is one thing I want to mention. The patient was operated for lipoma nerve in a divisional city private hospital by surgeon and with anesthetists. But there was no facility for emergency. And also the anesthetist failed to check it properly, preoperatively. And when it happened, they couldn't do it in time. And the patient had cerebral anorexia and died. So when we examined, the hospital was not licensed. The anesthetist didn't renew his license for 10 years. So these are also the one we should not follow. This one is a premature LSS. The patient, the radiologist give the full report, but the OG didn't care. And she did it LSS prematurely and the patient died. So this is one thing we should remember. We must value our axillary ultrasound, biopsy, and lab results. But I want to tell you, never ever trust them also totally. You have to correlate with your clinical finding because we are treating the patient, not the lab result or X-ray finding. And the other one is lack of cooperation. This is very important because as I saw, the nature of surgery, cooperation and the teamwork is very important. And operating on the dead patient, I have done it because I was doing lobectomy for C lung. And I said, this one is very smooth. But one house surgeon came in, he said, there was no pulse. So I asked them to inform the anesthetist who was outside the operation theater smoking. And when he came, I didn't know when the patient was died. So this sort of thing should not be happening. We need cooperation and coordination. And I had 2 patients where the reversal is incomplete. And I lost 1 patient, and the other patient, I know this anesthetist is not very reliable. So I watched. While I was watching, the patient respiration began slower, and I request another anesthesiologist, and we give more prostaglandin, and the patient survived. So this, I want to say, the cooperation. And also, we have met incidents of blood mismatch transfusion in a private hospital, not licensed, and they detect the mismatch after 3 units of blood transfusion. And the blame went to the technician who issued the blood after cross-matching. So these are the things I want to tell you that we need team operation. Surgeon alone cannot do it. So the teamwork is our main responsibility. So we must be beware that my mentor told me that there was no such thing as minor surgery. Beware that we are dealing with the life of patients and we have to do no harm to the patient. Because when you had experience or when you listen to the senior surgeon, you will see that the patient come for biopsy, excision of the neck bleeding. The patient come for some minor surgery and succumb because they think it's very minor, but the patient give with his life. So these are the thing we should bear in mind. I want to conclude it, but before conclusion, I was asked to say something about aesthetic practice. This aesthetic practice is very popular with customer demands. And also, there's because of medical marketing by mis and disinformation, and they are being done by specialists, plastic surgeon or specialty surgeon, and dermatologists, general physician, and even by non-medical non-medical personnel. So these should not be done. So we need, the results are very variable, but few complaints. And what is needed, and then no specialist, you must know that there is no specialist for aesthetic practice. Some people, they will say that we are specialists in aesthetic. There's no such thing. And then they need for guiding, who should do, what should do, and where it should be done. So to contain it, we need implementation of the guidelines. No approval by Ministry of Health, control aesthetic medical practice, take necessary action effectively. And you must do public education, and you should avoid advertisement by clinician and by media, which give mis and disinformation to promote by coercion and persuasion in medical marketing. So in conclusion, I want to say that beware of medical and surgical ethics since medical school. Now new curriculum contain this ethic, and I was very happy. Ethic guide us with principle in surgical practice for patients and community benefit. Please get lessons from my mistake and those of others. And we should be proud to be surgeons or noble profession by adhering to surgical ethic. Thank you very much. I'm sorry. I'm sorry that I overshoot the time, but when we discuss, it was to be about 1 hour, then 45 minutes, and then 30. So I prepared this, and this might be my last lesson. So please forgive me for overshooting the time. Thank you.
Thank you very much, Professor Brigadier General Myint, for your very comprehensive and wonderful presentation. Thank you.
May I invite next speaker, who's Professor Myint, a retired professor and head from Mandalay. He is also a good surgeon and also a good artist. He's a very good poet, and he started a liver transplant program in Mandalay. He's going to talk on mentor.
Good morning, ladies and gentlemen. It's a very privileged for me to present a talk about the mentor. I think which is in line with the theme of this conference: surgical progress, building skills, and saving lives. The mentor ဆိုတဲ့စကားလုံးကဘယ်လာလဲဆိုရင် 8BC မှာဒီဟိုမာရေးခဲ့တဲ့ Odyssey ဆိုတဲ့ epic poem မှာသူကဒီဘုရင်ကြီးကစစ်မထွက်ခင်မှာသူ့ရဲ့တငယ်ချင်းအဲ့ဒီမှာ character တယောက်ရှိတယ်သူ့နာမည်က mentor သူ့ကိုသူ့သားလေးကိုကလေးဘွားနေပြီးတော့လူကြီးဖြစ်အောင်ပြောထောင်ပေးဖို့အတွက်အပ်ခဲ့တာအဲ့တော့ when you look at the Oxford Dictionary, mentor is a person who offers support and guidance to another one. အဲ့တော့ဒါဆိုရင်ကျွန်တော်ဒါလေးကို verify လုပ်ချင်ပါတယ် teacher ဆိုတဲ့ဟာနဲ့ mentor ဆိုတဲ့ဟာနဲ့ဘယ်လိုကွာလဲပေါ့အဲ့နဲ့ဗမာ dictionary မှာကြည့်တဲ့ခါကျတော့ mentor ဆိုတဲ့ဟာလက်ဦးဆရာလို့ပြောတယ်အဲ့တော့ teacher ဆိုတဲ့ဟာကတော့ classroom based teaching ပေါ့ specific knowledge specific subject ကို deliver လုပ်ပေးတာကို teacher လို့ခေါ်တယ် mentor ဆိုတဲ့ဟာကတော့ he provides guidance support and advice based on his experience less formal more personalized he focused on the overall development personal as well as professional development with long-term goals. So, when we look at the history of mentoring in surgery, ancient period surgeons apprentices in sabio established practitioners nama toy tingeja. Emperor Paris French barber surgeon. He was the father of modern surgery and he emphasized on the hands-on training. The Johns Hopkins Hospital 1889 William Hosted was the first surgeon who established surgical training program to a handpicked lotare the very UABO thing a beer. The Taushia goes William Osler and the Harvey Cushions were now by time modern neurosurgeon father Pilame to a mentor in it. No, talk work not Emma, say Azuma. Emma, the general regulation and bio surgical mentoring schemes you, Sabio introduced Lulaja. No, history of mentoring in surgery, Pramabino apprentice Nina Sare, Nabinaro structured mentoring program in it. Pilare, have we met? Below Pyong, fundamental balancing mentor, mentee, relationship. So what is mentoring? It's a process by which experienced and empathic person who is mentor guides another individual, the mentee, for personal and professional development. Mentoring types are informal and formal. Informal is a general daily surgical practice. Spontaneous relationship between senior and junior colleague. I look at how informal look for it. I'm ad hoc mentoring with her. When a daily surgical what round say, OT every day setting ma တွေ့ရတယ် casual conversation စီမှာ senior surgeon ကနေပြီး junior တွေကို advice လုပ်တဲ့ဟာ ad hoc mentoring လို့ခေါ်တယ် နောက်တစ်ခုက role modeling ပေါ့ အဲ့မှာ senior surgeon က he sets an example through their behavior clinical decision making patient interactions and leadership style ဒီပုံလေးမှာကြည့်မယ်ဆိုရင်နောက်ကလူတွေအများကြီးကရှေ့ကဥဆောင်သွားတဲ့ဒီ mentor နောက်ကိုလိုက်တယ် observe လုပ်တယ် interact လုပ်တယ်နောက်တစ်ခုကျတော့ social mentoring အဲ့ဒါကြတော့ဒီကျွန်တော်တို့ social events တွေ informal gathering တွေမှာ senior surgeons ကနေပြီးတော့ personal professional advice တွေပေးပြီးတော့ဒီလိုနေရာမှာဒီလိုနေရတယ်ဒီလိုထိုင်ရတယ်ဒီလိုဆက်ဆံရတယ်ပြောရဲဆိုတဲ့ဟာကိုတင်တဲ့ဟာ social mentoring လို့ခေါ်ပါတယ်နောက်တစ်ခုကျတော့ reverse mentoring အဲ့ဒါအခုခေတ်မှာပိုးလို့လာတယ်ဘာကြောင့်လဲဆိုတော့ technology ideas တွေပြောင်းလာတဲ့အချိန်မှာ junior စီကနေပြီးတော့ senior တွေကပြန်တင်ရတဲ့ဟာဒါလည်းတင်ရမှာပဲသူ့ရဲ့ laparoscope လိုဟာမျိုးတွေပေါ့အဲ့တော့နောက်တစ်ခုကျတော့ formal mentoring which is controlled by an organization it aims to provide support by following the structured program ဒီမှာဆိုရင် institution or professional society ကျွန်တော်တို့ surgical society လိုဟာမျိုးတွေကနေပြီးတော့ဒီမှာတင်မဲ့ဆရာနဲ့တင်ခံမဲ့တစ်ဖက် recruitment လုပ်ရတယ်ဒီဘက်မှာကြည့်လိုက်မယ်ဆိုရင် on the left side ပေါ့နော်အဲ့မှာဒီ transplant surgeon ကိုဒီ mentorship program မှာဒါဘယ်လိုရှောက်ပါဆိုရဟာဒီဘက်ကကျတော့ mentee ပေါ့နော်အဲ့ဒီ social mentorship program မှာ training နဲ့ faculty နဲ့ဘယ်လို pairing လုပ်ရလဲဆိုတဲ့ခါကျတော့ဒီ training တယောက်ကဘာဖြစ်ချင်တာတော့သူ့ရဲ့ goals ပေါ့နောက်တစ်ခါကျသူ့ရဲ့ specialty ကပါတော့ပြီးခဲ့ကြတော့သူ့ရဲ့ career stage ပါတော့ အဲ့ဒီပုံမှာမူတည်ပြီးတော့စဉ်းစားပြီးတော့ pairing လုပ်ပေးရတယ်အဲ့ခါကျတော့ဘာကောင်းမှလဲဆိုတဲ့ခါကျတော့ဒီ pairing ဆရာနဲ့တပည့်နဲ့ pairing လုပ်တဲ့အချိန်မှာငါကံကောင်းလို့ဒီလိုတော်တဲ့ဆရာကြီးနဲ့တွေ့လိုက်ရတယ်ပေါ့ဒါမှမဟုတ်လည်းငါကံမကောင်းလို့အဲ့လိုတွေ့ရဆိုတဲ့ဟာမျိုးတွေမရှိတော့ဘူးဘာကြောင့်လဲဆိုရင်ပြီးတဲ့ခါကျရင်သူတို့မှာ clear objectives တွေရှိရမယ် define roles တွေရှိရမယ် scheduled interactions တွေရှိရမယ်this is one of the examples of mentorship process according to right college of surgeons of England တို့ RCS ဆိုင်တို့ရဲ့ key principles တွေမှာ the mentoring relationship must be freely entered into or volunteer အနေနဲ့ပါတာဘယ်သူမှပါဆွေးလို့မဟုတ်ဘူးသူတို့နှစ်ယောက်ကြားမှာလုပ်တဲ့ discussion က very confidential except for patient safety now mentor mentee relationship မှာ boundaries တွေချထားရမယ် goals တွေ outcomes တွေရှိရမယ်တခါ time commitment ရှိရမယ် duration of mentor mentee relationship ကဘယ်လောက်ကြာအောင်ထားမှာတော့နောက်ပြီးတော့တစ်လမှာဒါမှမဟုတ်တစ်နှစ်မှာဘယ်နှခါတွေ့မှာတော့တွေ့တဲ့ခါကျရင် mentee ကနေပြီးတော့သူလှုပ်ချင်တဲ့ agenda ကိုသူက set လုပ်ပေးရတယ်အဲ့ပုံမှာမူတည်ပြီးတဲ့ခါမှာ mentor ကနေပြီးတော့ response လုပ်ပေးတာအဲ့တော့ပြီးတဲ့ခါကျရင် mentoring contract ဆိုတာသူကဒီ Ireland ထုတ်ထားတဲ့ model တစ်ခု grow model ပေါ့တပည့်ကဘာလို့ချင်တာတော့ goal ပေါ့နော် where are you now what could you do and what will you do အဲ့တော့ mentorship style တွေရှိပါလေpeer mentoring ပေါ့ similar levels of the experience ရှိရလူအရေးကြုံလာတဲ့ခါကျရင်တယောက်နဲ့တယောက်ကူညီတဲ့ဟာ peer mentoring လို့ခေါ်တယ်နောက်တစ်ခုကျ group mentoring ကတော့ one mentor mentee more than one သူတို့ပြင် less well equipped institutions ဒီမှာဒီလိုပုံစံမျိုးကတုံးတက်နိုင်တယ်နောက်တစ်ခု self directed mentoring အဲ့ဒါကြတော့ learner ကိုယ်တိုင်က highly motivated learner သူကဒီ training process မှာသူကစပြီးတော့ lead လုပ်သွားတယ် mentor က general advice ပဲပြီးပြီးတော့လုပ်သွားတဲ့ setting မျိုးနောက်တစ်ခု speed mentoring flash mentoring လို့လည်းခေါ်တယ်သူကတခါတရက်လောက်ပဲတွေ့ရင်တွေ့မယ်ဒါမှမဟုတ်လေ long day တွေ့ရင်တွေ့မယ်ဒါပေမဲ့ဒီလိုမျိုးတွေ့တဲ့အချိန်မှာတစ်ခါတွေ့ few minutes ပဲကြာအဲ့ဒါကို speed mentoring လို့ခေါ်တယ်နောက်တစ်ခါကျ virtual mentoring အဲ့ဒါတော့ကိုယ်ဖြစ်ပြီးသွားတဲ့အချိန်မှာတော့ဒီတယောက်တွေ့ဖို့ခက်ခဲတဲ့ခါကျတော့ virtual method techniques တွေနဲ့mentoring လုပ်တဲ့ဟာဒါလေးကိုလည်းကျွန်တော် surgical society ဒီစီကနေပြီးတော့ formalize လုပ်နေအောင်ကြိုးစားနေတယ်အဲ့တော့တယ်လီဖုန်းနဲ့တယောက်ပြောလို့ရတယ် email ဒါမှမဟုတ်လည်း in person face to face ကပထမဆုံးတွေ့အချိန်မှာတော့အကောင်းဆုံးမရရင်တော့ Skype တွေပေါ်နဲ့တွေ့လို့ရတယ်ဘယ်လိုပုံစံနဲ့ပဲတွေ့တူညီရဲ့ချက်ကဘာလဲဆိုရင် mentor နဲ့ mentee မှာ there should be trust mutual respect and clear communication ရှိရအဲ့တော့ roles of mentors in surgical training ပထမဆုံးကတော့ cheerleaders ပေါ့ဒီကာတွန်းပုံလေးမှာပါတဲ့ cheerleaders ဆိုမဟုတ်နော်သူက emotional support လုပ်ပေးရမယ်နောက်ပြီးတော့သူရဲ့ကိုယ့်တစ်ဖက် stress တွေ failure တွေရှိတဲ့အချိန်မှာဒါကို overcome လုပ်နိုင်အောင်ကူညီရမယ် mental resilience ဆိုပြန်ပြီး bounce back ဖြစ်လာအောင်ကူညီရမယ်နောက် self doubt ရှိတဲ့နေရာမျိုးမှာဒီ mentee ကိုကူညီတဲ့ဟာကို cheerleaders လို့ခေါ်တယ်နောက်တစ်ခါကျ advisors it is concerned with the career paths ရွေးတဲ့အချိန်မှာ fellowship သွားမှာလား research လုပ်မှာလားဒါမှမဟုတ်လည်း complex surgical decisions တွေလုပ်ရတဲ့အချိန်မျိုးဥပမာ set specialty တစ်ခုကိုဝင်သွားမှာလားနောက်ဆုံးအရေးကြီးတဲ့တစ်ခုကတော့ work life balance ပေါ့အဲ့မှာပါ advice ပေးဟောနောက်တစ်ခါ coaches ပေါ့နော်အဲ့တော့ it is mainly concerned with technical skill decision making skill hands on training in the OT ပြီးတဲ့အခါကျရင် constructive feedback ပြန်ပေးရမယ်အဲ့လိုပေးခြင်းအဖြစ် it can improve surgical training ရဲ့ techniques ကိုပိုကောင်းလာနိုင်တယ် clinical judgment skill ကိုပိုကောင်းလာနိုင်တယ်နောက်တစ်ခုကတော့ sponsors ပေါ့ sponsors တွေကတော့လွယ်မှန်းမယ်ဆိုရင်တကားဖွင့်ပေးလို့ပေါ့ဒါ he provides networking opportunities and career advancements. The mentee ရဲ့အားသာချက်အားနည်းချက်ကိုသိပြီးတဲ့အချိန်မှာဒီကလေးအဖြစ်တော်တယ် I would like to recommend him for prestigious training programs, leadership roles, research လုပ်နေအောင်ကူညီပေးရမျိုးဒီ mentor ကသူ့မှာရှိတဲ့ influence ကိုသုံးပြီးတော့ mentee မဖွင့်နိုင်တဲ့တကားကိုဖွင့်ပေးလိုက်တဲ့ဟာကိုဒါကို sponsor ဆိုခေါ်တယ်အဲ့တော့ဒီလိုမျိုးဒီ values roles တွေကိုမျှတအောင်သုံးခြင်းအဖြစ် we can produce successful and confident surgeon ပေါ့အဲ့တော့ good mentor တယောက်ဖြစ်ဖို့တက်ကအရေးကြီးတဲ့ common factors တွေဘာတွေလို့လဲဆိုတော့နံပါတ်1က taking interest in others စိတ်ဝင်စားမှုရှိရမယ်သူများအတွက် and then သူများကိုတိုးတက်ကြီးပွားအောင် develop ဖြစ်လာအောင်ကူညီခြင်းနဲ့စိတ်ရှိရမယ် being approachable ဖြစ်ရမယ် open minded ဖြစ်ရမယ် non judgmental and objective integrity ရှိရမယ်သူကိုယ်တိုင်ကလည်း confident ဖြစ်ရမယ်အဲ့တော့ဒီ mentor mentee relationship မှာ effective questioning လုပ်နေရမယ် active listening လုပ်နေရမယ်အဲ့တော့ပြီးရဲ့ခါကျရင် mentee ကနေပြီး mentor challenge လုပ်တဲ့အချိန်မျိုး question မေးတဲ့အချိန်မျိုးမှာ calm and constructive manner နဲ့ဒါကိုဒီလုပ်နေရမယ်ပြီးရင် mentor တယောက်ကခုနဆရာကြီးBrig ကျန်ဆရာကြီးပို့ချုပ်များတဲ့ပြောပါတယ်လို့ပဲကိုယ့်ရဲ့ဘဝကိုပြန်ပြီးတော့ကိုယ့်ရဲ့ practice ကိုပြန် reflect လုပ်ပြီးတော့ ethics တွေကိုသူပြောလာတာအဲ့ဒါကိုလည်းကျွန်တော် appreciate လုပ်ပါတယ်အဲ့လိုမျိုး mentee ကိုလည်းသူ့ဘာသာသူပြန်ပြီးတော့ reflect လုပ်ပြီးတော့ဒီ positive feedback ပြန်ပေးဖို့လိုပါတယ်နောက်ပြီးတော့တွေ့ရမယ့် sessions ကိုဖြစ်နိုင်ရင် cancel မလုပ်ပါနဲ့အဲ့တော့ these are the benefits of mentorship နော်အပေါ်ဆုံးမှာကြည့်မယ်ဆိုရင်ဒီဘက်ပေါ်မှာ self confidence တက်လာတယ် performance တက်လာတယ် job satisfaction ကောင်းလာတယ်အဲ့လိုပဲ mentor မှာလည်းသူ့မှာ performance ကောင်းလာတယ် insight တွေပြောင်းလာတယ် he can adapt management style so organization တက်ကြတော့သူ့မှာ staff morale တက်လာတယ် staff retention တွေလုပ်နိုင်လာတယ်ပြီးရဲ့ခါကျရင်တခြား employees တွေအသစ်တွေကို attract လုပ်နိုင်လာတယ်ဒါအားလုံးရဲ့ကျေးဇူးကဘယ်မှာသွားရှိလဲဆိုရင် patient safety ကျွန်တော်တို့ရည်မှန်းတာ patient safe ဖြစ်ဖို့လိုတယ်အဲ့ဒီအတွက်ပါဒီ quality စီရောက်လို့ရနိုင်တယ်အဲ့တော့ခုနကျွန်တော်ရှေ့မှာပြောခဲ့တယ်ဒီ mentoring ဆိုတာဘာလို့ဆိုတော့လူတစ်ယောက်ရဲ့ personal နဲ့ professional development ဖြစ်လာအောင်လုပ်ပေးနိုင်ခြင်းကိုခေါ်တာအဲ့တော့ personal development ဆိုတဲ့အချိန်မှာ technical expertise တွေပါမယ် communication skills emotional resiliency adaptability reflection and self-assessment ပါ professional development မှာ leadership နောက်ကျွန်တော်တို့ဌာနမှုတွေဖြစ်တဲ့အခါကျရင် teaching research အဲ့ဒါတွေပါလုပ်နိုင်ရမယ်ဒါဆိုရင် benefits of mentorship ပါများလုံးမကြည့်တဲ့အခါကျတော့ mentee ပေါ်မှာလည်းရှိရယ် mentor ပေါ်မှာလည်းရှိရယ် organization ပေါ်မှာလည်းရှိရယ် Royal College of Surgeons recommends mentorship program for all surgeons regardless of their seniority or the stage of their career အဲ့တော့ surgeon တယောက်မှာအဓိကအဖြစ် three different stages ရှိရယ်ပထမဆုံး stage ကတော့ဒီဘက်ဆုံးမှာ surgical training MSc တက်တဲ့အချိန်မျိုးပေါ့နောက်တစ်ခုကကျတော့တက်ပြီးတော့ MSc အောင်သွားတယ်ပြီးတော့  3 to 5 years after training attending surgeon တွေနဲ့လုပ်ရတဲ့အချိန်နောက်တစ်ခါကျတော့နောက်ဆုံးကျတော့ mid career phase ဆိုပြီးတော့ရှိတယ်အဲ့ early 3 to 5 years of ခုန training ကနေပြီးတော့ကျွန်တော်တို့ဒီ first assistant လုပ်မယ်ဒါမှမဟုတ်လဲ team leader တွေလုပ်တဲ့အချိန်မျိုးမှာဒီ department မှာဒီထွက်လာတဲ့ surgeon တွေကဒီ new role တွေရလာတယ် training period မှာမသင်ခဲ့ရတဲ့ dealing with complaints litigation တွေ possible communications တွေကို deal လုပ်နိုင်ပါအောင်သူကစူးစမ်းရမယ် leadership role လဲပါလာပြီအဲ့လိုအချိန်မျိုးမှာသူ့ကိုထောက်ပံ့ကူညီမဲ့ mentor မရှိဘူးဆိုရင်သူ့တက stress အများများအဲ့လိုအချိန်မှာ there should be a senior colleague or mentorship program who can provide or who can support and guide လုံးပေးနိုင်မယ်လို့ရှိဖို့လိုတယ်သူ့ရဲ့ career pathway စီအတွက်အဲ့တော့နောက်တစ်ခုကကျတော့ mid career surgeons ပေါ့ကျွန်တော်တို့ consultant ဖြစ်သွားပြီးခါကျရင်ဘာဆက်လုပ်ရမလဲဆိုတော့ self-improvement in terms of adoption and mastering of new technical skills တွေဒါ professional patient management တကယ်တော့အဲ့လိုလုပ်ဖို့ကြိုးစားပြီးမယ်လေကိုယ့်ရဲ့ daily practice မှာရန်ကိုအလုပ်များတဲ့ခါကျတော့မလုပ်နိုင်ကျွန်တော်စဉ်းစားမိသေးတယ်ကျွန်တော် MSc ပြီးပြီးတော့2နှစ်3နှစ်နေတဲ့ခါကျရင်နေရောက်သွားတယ်အဲ့မှာဒေါက်တိတ်များတက်ရင်ကောင်းမလားပေါ့ဒေါက်တိတ်တက်ရင်ကောင်းမလားဒေါက်တိတ်တက်တဲ့ခါကျရင်တော့မစိုးဘူးကို့မှာတစ်ခုခုလုပ်စရာရှိလာတယ်ပြီးတဲ့ခါကျရင်ဒီကိုယ့်ရဲ့ career path ကိုမှာဆက်ပြီးတော့လုပ်ဖို့စဉ်းစားမိရအများကြီးရှိလာတယ်အဲ့တော့ဒီအဲ့ consultant level ကနေပြီးတော့ဆက်ပြီးတော့ပူသွားမဲ့ဘဝ leadership ထဲမှာပါသွားနိုင်တယ် academic position တစ်ခုကိုရောက်နိုင်တယ်အဲ့တော့ leadership position မှာပါတဲ့ခါကျရင်သူ့မှာ professionalism တို့ competence ဖြစ်တာတို့ motivation innovation teamwork communication skills တွေ decision making skills တွေလိုးလာပြီသူတို့တွေကိုဘယ်လိုတောင်းတင်မလဲအဲ့ဒီအချိန်မှာကျွန်တော်တို့ course တွေလိုက်တက်ပြီးတော့မရအောင်ဘာရှိဖို့လိုလဲဆိုရင် mentoring coaching networking system ရှိဖို့လိုတယ် they can only develop these leadership skills only through experience and observation အဲ့တော့ဒီလောက်ကောင်းတဲ့ mentorship programs တွေကိုနိုင်ငံတိုင်းမှာမလုပ်နိုင်သေးပါဘူး surgery department ထဲမှာလည်းကျွန်တော်သိတယ်တော့မလုပ်နိုင်သေးပါဘူးUK မှာဆိုရင်လည်း there was an initiative from the Royal College of Surgeons which has been established to support surgeons during their first 5 years after their training အဲ့တော့ရှင်းပိုင်းလေးတော့ပြီးတော့ခဏလေးနားလိုက်ကျွန်တော်ရဲ့ဘဝကိုပြန်ပြီးတော့reflect လုပ်ချင်ပါတယ် who are my mentors ဆရာကြီးကျွန်တော်အများကြီးတော့မကြုံဘူးပါဘူးကြုံခဲ့တဲ့ချိန်တုန်းကကျွန်တော်ကလည်းငယ်သေးတယ်ဒါပေမဲ့ဆရာကြီးနဲ့ပတ်သက်လာကျွန်တော်မှတ်သားထားတာပေါ့နော် Royal College of Surgeons of Edinburgh ဆရာကြီးကိုတော်တော်လေးကိုအသိမှတ်ပြုပါတယ်ပြီးတဲ့အခါကျတော့ဆရာကြီးရဲ့ lunch time talk တွေပေါ့နော် professional ဇင်းနဲ့ပတ်သက်တဲ့ဟာတွေတော်တော်ကိုမှတ်သားပြီးတော့လိုက်နာပြီးတော့လုပ်ဆောင်ရပါတယ်ဆရာကြီးရဲ့မြင့်ဆရာကြီးအားလုံးသိတဲ့ဆရာကြီးပါဆရာကြီးဦးဝင်းမြင့်ဒီနေ့ရောက်ကိုဘာလို့တွဲပြီးတော့ပြလဲဆိုတော့ဆရာကြီးတို့ကျွန်တော်အမှတ်မမှားဘူးဆိုရင်ပေါ့လေနိုင်ငံခြားသွားပြီးတော့ conference တက်တဲ့အချိန်မှာဆရာကြီးတွေကဒီတခြားနိုင်ငံ surgeon တွေနဲ့တွေ့ပြီးတော့ networking လုပ်တယ်လုပ်ချင်းအဖြစ် Elsa ဆိုတဲ့ဟာဗမာပြည်ကိုပါလာတယ်လို့ထင်ပါတယ်ကျွန်တော်အမှတ်မမှားရင်ပေါ့အဲ့ခါကျတော့သူတို့တွေသွားတယ် conference တက်တယ်ဆိုတာဈေးဝယ်ဖို့မဟုတ်ကျွန်တော်တို့ဒီ surgical society develop ဖြစ်လာအောင်သူတို့တွေကဒါတွေကိုစူးစမ်းခဲ့တာဆရာကြီးဦးဝင်းမြင့်နဲ့ပတ်သက်ပြီးပြောစရာနောက်တစ်ခုရှိပါသေးတယ်ပြီးမှပြောဟိုဘက်ကမြင်ရတဲ့အသားဖြူနေတဲ့ဆရာတော်ဆရာဦးမောင်ခင်ပါခုန mentoring မှာ peer mentoring ပေါ့နော်ကျွန်တော်တို့က MSc တူတက်ခဲ့တယ်ကိုရှင်ဒါလေးတော့ကိုရှင်လိုမယ်သူကအသက်လည်းကြီးတယ်ကျွန်တော်သူပြောစကားဆိုနားထောင်ပါပါတယ်အဲ့ဒါပြီးရခါကျတော့ဒါကျွန်တော်တို့ဆရာကြီးဦးဟန်စောနဲ့ပတ်သက်ပြီးတော့သူ့ရဲ့ပျော်ပြောင်းတဲ့ဘိုင်းလေးကိုအရင်ပြောပြစေအဲ့မှာကျွန်တော် MSc တက်တယ်ကျွန်တော်ရဲ့ dissertation က skin graft အဲ့မှာဟာပေါ့ဒီ graft မလုပ်ခင်မှာအနာကိုတက်ပွင့်ရရတယ် graft လုပ်ပြီးသားရှိမှာတက်ပွင့်ရရတယ်တဲ့ခါကျတော့ဘာလို့လုပ်တဲ့ခါကျဆေးရိပ်နဲ့ကျွန်တော်ကိုရှင်းမခင်ဗျာတက်ပွင့်ရိုက်ပြီးလားမရသေးပါဘူးဆရာကြီးတခါနောက်3ခါလောက်ရောက်တဲ့ခါကျတော့ဘာလို့မရိုက်သေးရလဲဆိုကျွန်တော်ဘာမှမဖြေဘူးကျွန်တော်မန်လေးမှာ MSc သွားတက်တာအဲ့ခါကျတော့လာဆိုပြီးတော့ patient ကိုအပြင်မထုတ်နေအောင်ရမယ့်နေရာမှာသူ့ကင်မရာကြီးကိုထုတ်ပြီးတော့ဓာတ်ပုံရိုက်ပြီးတဲ့ခါကျတော့မင်းဓာတ်ပုံကူကိုပတ်စံမရှိဘူးလားကျွန်တော်ဘာမှမဖြေဘူးကြောက်ယူသွားဆိုပြီးတော့ကျွန်တော်အဲ့လိုမျိုးသူကတင်ပေးခဲ့တာသူနောက်တစ်ခုကကြတော့ဒီဝါရောင်းလုပ်ပြီးတဲ့ OT လက်ဖြတ် electric OT ရှိရစဉ် register ဝါရောင်းဆိုပြီးလုပ်ရတယ်လုပ်တဲ့အချိန်မှာဒီကိုက assess ပြန်ရမယ့် case ကိုpatient အကြောင်းကိုဂါဂနနာသိရလားလို့မေးတယ်ကိုခွဲရမယ့် case ဆိုရင်လည်း ကိုယ်ပါဇက်နဲ့ခွဲခိုင်းတယ်သူချင်းနဲ့မှကျွန်တော်တို့ကဝင်လို့ရတယ်အဲ့လိုမျိုးတုံသင်ခဲ့တဲ့ဆရာကြီးတယောက်ပါဒါတော့ကျွန်တော်ဒီကဆရာကြီးအားလုံးသိတဲ့ဆရာကြီးဦးနော်မလာပါသူနဲ့ပတ်သက်ပြီးတော့ခြားအများကြီးရတယ်ပြီးတော့ဆရာကြီးကဒီသူ့ဘွားမှာတကယ်ကိုယောဂအကြီးကျယ်ဖြစ်တဲ့ချိန်မှာဒါကိုသူကနေပြီးတော့ train လုပ်ခဲ့တဲ့သူ့ရဲ့တပည့်တွေကိုပြန်ခွဲခိုင်းတာအဲ့လောက်ထိအောင်တပည့်ကဆရာတဲ့လက်ဆောင်ထက်တယ်မထက်ဘူးကျွန်တော်မပြောလို့ဘူးဒါပေမဲ့ယုံကြည်မှု respect နဲ့ကိုဆရာကြီးကိုခွဲပေးရတယ်နောက်ချက်ကကျွန်တော်ပြောပါတယ်ကျွန်တော် labor transfer လုပ်တော့မယ်ဆိုတဲ့ခါကျတော့အဲ့ဒီတော့ February 12 ရက်နေ့မတိုင်ခင်17 ရက်နေ့မှာဆရာကြီးဦးထုံးလဲရှိတယ်အဲ့မှာ transfer လုပ်နေနေနောက်တနေ့မနေ့ကူသွားတဲ့အချိန်ကျတော့ဖျောက်ငါပြင်မပြီးွားဆိုပြီးတော့အေးရဘုံပလက်ကြီးဆန်ပြီးလဲမိမလေးမှာ labor transfer လုပ်မယ်ဆိုရင်မလုံးနဲ့ညီကြီးဆွေးစီးကနေပြီးစာအုပ်တောင်းဖတ်ပြီးတဲ့ခါကျမှငါလာပြီးမှမဲလုပ်ဆိုပြီးကျွန်တော်အဲ့လိုမှားသွားတာဒါဆရာကြီးဦးကြီးဆိုပါကျွန်တော်အမေကိုအမေရိကန်ဟာနေရဖြစ်တော့ခွဲဖို့လူတယ်ဆရာကြီးကနေပြီးတော့ကျွန်တော်အမေရိကန် student ရှင်းပြ counseling pre-operative counseling လုပ်တယ်အဲ့ဒီအချိန်မှာဒါဆရာကြီးကဘယ်လိုရှင်းပြတဲ့ခါကျတော့ကျွန်တော်တို့ဆရာဝန်ဖြစ်သေးရဲ့လူတယောက်နားလည်အောင်ရှင်းပြနိုင်တဲ့အတွက်ကြောင့်မလို့ဒါဆရာကြီးလည်းလမ်းလို့အောင်ဆရာကြီးဒါတော့ဆရာကြီးဥစိန်မြင့်ပါအဲ့တော့အများကြီးတွေကနှစ်ခုပါတစ်ခုက Journal of the American College of Surgeons ပေါ့နော်အဲ့ဒီမှာဆရာကြီးက member ဝင်ထားတယ်ကျွန်တော်နိုင်ငံခြားပြောင်းလာကစားအင်တာနက်ကိုဘယ်လိုကောင်းမှမသုံးရမလဲဆိုတာမသိဒါပေမဲ့ဆရာကြီးကကိုရှင်းပြတာကျွန်တော်ရဲ့ user name ဒါ password ပြီးတယ်ကျွန်တော်ဆက်ဖတ်ခိုင်းတယ်အဲ့မှာကျွန်တော်ဖြည်းဖြည်းနဲ့အမြင်ကျယ်သွားတယ်နောက်ချက်ကကျတော့ liberalization တွေကိုလုပ်ဖို့လိုတဲ့ခါကျတော့ကိုရှင်းပြခင်ဗျာဆရာဥက္ကမောင်ကြီးစီမှာတွားတင်လိုက်ဥက္ကမောင်ကြီးကဆရာချင်းဥက္ကမောင်ကြီးဆရာချင်းဆရာဥထုံးတို့ဆရာဥက္ကမောင်ကြီးအဲ့သူစီမှာကျွန်တော်က assist ဝင်တယ်၄ခါရောက်တော့ assist ဝင်တယ်ပြီးတဲ့ခါကျတော့ပြန်လာပြီးတဲ့ခါကျတော့ဆရာဥစိန်မြင့်ခွဲတဲ့ချိန်မှာကျွန်တော်က assist ဝင်ရတယ်အဲ့တော့ဆရာကြီးလည်းပြင်ရည်ရပါတယ်ဆရာကြီးနောက်တစ်ခုကကျတော့ patient နဲ့ဒီလုပ်တဲ့အချိန်မှာကြာနာပဲပြီးမယ်ဆိုပြီးတော့ပြောရတာဒါဆရာကြီးဥစိန်မြင့်ရဲ့ဆိုင်ပါလေဆရာဦးသိတယ်သူကကြတော့ကျွန်တော်မန္တလေးကို MSc တက်ဖို့ရောက်လာတဲ့အချိန်မှာဆယ်ယူမှာဆိုတာဝတ်ထဲမှာ round လုပ်ရင်စာမေးရင်ကျွန်တော်ဘယ်တော့မှမရဘူးစိတ်ညစ်ပြီးတော့ကျွန်တော်က round ပြီးတဲ့အချိန်မှာ first season နေတဲ့ခန်းလေးကိုပြန်ဝင်လာတယ်အဲ့ဒီအချိန်မှာဆယ်ဦးသိန်းလေးကနေပြီးတော့ထပ်ပြီးတော့မေးခွန်းတွေထပ်မေးပြန်အောင်နေတိုင်းတခါလည်းမဟုတ်ဘူးမေးရခါကျကျွန်တော်နောက်ဆုံးကျတော့စိတ်ညစ်လာပြီးတော့ဆရာကျွန်တော်အဖြေပြောမှလားဖြေမပြောရင်မမေးပါနဲ့တော့ဗျာလို့သူတောင်းပန်ယူရတယ်ငါပြောပါမယ်ကွာမင်းဖြေပြောပါမယ်ဖြေတော့ဖြေကြည့်ပါဦးအဲ့လိုမျိုးသူကကျွန်တော်တက်ဆိုရင်ဒါဆိုရင်ခုနဒီ mentor တစ်ခုမှာသူက cheer leader လို့ဟာမျိုးမှာပါတယ်နောက်ပြီးကြတော့ social mentoring မှာလည်းသူကပါတယ်ဟော channel သူတော်တဲ့ချက်တွေအများကြီးတွေကကျွန်တော်ရဲ့မှတ်သားထားတဲ့တစ်ခုပေါ့နော်ဒါကတော့ဆရာဦးသန်းဆွေ2ယောက်ရှိခဲ့တယ်ပေါ့လေဒါယူရိုဦးသန်းဆွေသူကြည့်တိုင်းအေးစစ်စစ်နဲ့လူမွေးကြီးလို့ခေါ်တယ်သူကကျွန်တော် major လုပ်ချင်တဲ့ခါကျတော့ဆရာကျွန်တော်ကို assist ဝင်ပေးပါအေးဆိုအဲ့လိုမျိုးအမြဲတမ်းကျွန်တော်ပူညီခဲ့တယ်နောက်သူretireသွားပြီးတဲ့အချိန်မှာကျွန်တော်ထန်ထမှုဖြစ်တဲ့အချိန်မှာလမ်းမှာတွေ့တဲ့ခါကျရင်ကိုချင်းမြင့်ခင်ဗျားနဲ့ပတ်သက်ပြီးတော့ကောင်းတဲ့သတင်းကဒီလိုမကောင်းတဲ့သတင်းကဒီလိုဆိုပြီးတော့ကျွန်တော်ဆုံးမတယ်အဲ့တော့ဒါလည်းကျွန်တော်ဆရာတယောက်ပါဒီပုံမှာကြည့်လိုက်ရင်ဆရာကြီးဦးရဲမြင့်ဆရာကြီးဦးဝင်းမြင့်ဆရာဦးဟန်စောဟိုဘက်ကမျက်မှန်လေးနဲ့ပုံကိုရကျွန်တော်ပေါ့ဒီဘက်ဒေါက်တာဆွိုင်းပေါ့နော်အဲ2004ခုနှစ်မှာ Surgeons Conference ကိုမန္တလေးမှာလုပ်တဲ့ချိန်မှာမန္တလေး MMA ကမဟုတ်ဒီယူပြီးတော့ချမ်းမြေနေလိုက်ရင်ဂလုတ်ကလစ်နဲ့နေထားလေးမှာဆွိုင်းကြီးကရောက်လာအဲ့မှာဆရာကြီးဦးဟန်စောနဲ့သူနဲ့ပြောဆိုနေတာကိုကျွန်တော်ကဘေးကနေကြည့်ပြီးတော့ကျွန်တော်အားကြဆရာကြီးဦးဝင်းမြင့်ဆိုအဲ့လိုကကြည့်လိုက်မယ်ပိမ့်လေးပိုးတော်ပိန်သွားသေးတယ် Surgeons Conference မှာဘာကြောင့်လဲဆိုတော့ကိုကြီးမင်းကျွန်တော်ခင်သိန်းကပြောလာပြီရဲ့ ရှင်တည့်တည့်ဒါပဲလုပ်နေတာဘယ်တော့ပြန်လာမှလဲဆိုပြီးတော့ surgeon conference ကိုလုပ်နေတာကျွန်တော်ကသူ့ကိုကူညီရင်းနဲ့ဆရာကြီးကိုကူညီရင်းနဲ့ conference တစ်ခုကိုဘယ်လို organize လုပ်ရဆိုတော့ကျွန်တော်ဆရာကြီးစီကလမ်းလုပ်ရပါတယ်နောက်ပြီးတော့ဆရာကြီးစနီးကိုလည်းဘယ်လိုတောင်းပန်ရဆိုရလဲလမ်းလုပ်ရပါတယ်ဒါတော့ကျွန်တော်ကဒီ UPenn ပေါ့ University of Pennsylvania liver transplant surgical team နဲ့တွေ့တဲ့အချိန်မှာကျွန်တော်စီကတပည့်တွေပေါ့ခုနပြောတဲ့ sponsor role ပေါ့နော်ဒါဘသူ့လွှင့်ကောင်းမလဲဆိုတာစဉ်းစားပြီးတော့ရှင်းခတ်နေတဲ့ပုံမှာဒါတော့ Park I don't think Park is here Park နဲ့ဘက်ကဆရာဦးတန်းဆွေဆရာပြည်တန်းဆွေအဲ့တော့ကျွန်တော်တို့ social mentoring ပေါ့နော်ဒါဒီလိုနေရာမျိုးလေးမှာရင်းနှီးသွားတဲ့ခါကျတော့လေနောက်ပိုင်းဘာပဲလုပ်လို့ဘာကိုညီတော့အဆင်ပြေတယ်ဆရာဦးတန်းဆွေကဒီလိုကိစ္စမျိုးတွေမကောက်ကျွန်တော်ကျွန်တော်တို့ open surgery ပါ private hospital နန်းတော်ဆိုတဲ့ဆေးရုံမှာကျွန်တော်က patient တယောက်ခေါ်ဆုံးနေလယ်မှာပဲဆိုကြည့်တော့ ultrasound မှာ gallbladder ရဲ့ very contracted gallbladder ငါဘဝရဲ့80လောက်ရှိအဲ့နဲ့ဆရာပြည်တာကိုကျွန်တော်ကဆရာကျွန်တော်ကူညီပါအောင်ဆိုတော့သူခွဲပေးတယ်ကျွန်တော် assist ပြီးတဲ့ခါကျတော့ကိုရှင် walk around လုပ်ရင်ကိုရှင် round like သူရရှိကျွန်တော်ပြောနာမည်မခံဘူးနောက်ကနေလုတ်ပြီးသွားတယ် encourage လုပ်တယ်လုတ်ပါဆိုပြီးတော့ဒါဆရာကြီးဘာတော့ပြပါတယ်ဒါတော့ဆရာကြီးဦးဟန်ဝင်းပုံရှာလို့မတွေ့လိုက်လို့ဆရာကြီးဦးဟန်ဝင်းတို့ဆရာဦးထွန်းဦးတို့ဆိုတာဒီ surgery department head စောဖြစ်ခဲ့တဲ့လူတွေဆရာဦးသိန်းလွင်ပါဝင်သူတို့ဆရာဦးထွန်းဦးကနေပြီးတော့သူစကားတခုစောက်လိုက်မစင်း well အဲ့လိုမျိုးလေးစပြီးတော့ပြောရမယ်ဆိုတော့ခုတော့လို့တော့မှသူစဉ်းစားရင်းနဲ့နောက်ကလိုက်လာအဲ့တော့အဲ့လိုမျိုးကိုယ့်ရဲ့ brother ပေါ့နော်စီကနေပြောကျွန်တော်တင်ခဲ့ရည်လေအများကြီးပါဒါ social mentoring တစ်ခု gathering တစ်ခုပါဆရာကြီးကပြောရပါတယ်အဲ့တော့ဆရာဦးတို့လင်းဆရာဦးသိန်း5ဟိုတောင်းထိုက်ကြီးအဲ့တော့ဒီဘက်ကတယောက်တော့မပြောတော့ပါဘူးအဲ့တော့ in conclusion ပေါ့နော် mentoring in surgery has a profound and lasting impact on the profession. Through mentorship, surgery as a profession is able to pass down its rich history of knowledge, values, clinical wisdom, ensuring that new generations of surgeons continue to maintain high standards of care. Moreover, surgical mentoring nurtures a culture of collaboration and mutual respect. While there are challenges associated with mentoring, the benefits far outweigh the difficulties. By embracing this legacy, surgeons can pass the scalpel to the next generation with confidence, not just in their technical skills, but in the strength of their character. The greatest good you can do for another is not just to share your riches, but to reveal to him his own. အဲ့တော့ကျွန်တော်ခုနပြောသွားတဲ့ example စီထဲမှာဆရာဆိုတာဂျင်းကတပည့်ပါပဲတပည့်ဆိုတာလေတစ်ချိန်မှာကိုယ့်ဆရာဖြစ်မဲ့သူပါအဲ့တော့လက်ရှိသက်ရှိရှင်များရှိနေတဲ့ဆရာကြီးများကိုကျွန်တော်တို့တပည့်ကနေ့လေတနားရီမှာကြော်ရင်းနဲ့ဆရာကြီးများကျေးဇူးအောင်းပေးပါတယ် Thank you very much.
Thank you very much, Xiao Myint, for your very interesting talk. Now we are handing the floor back to the Master of Ceremony.
Thank you very much, Chairpersons and Professor, for your valuable presentation. The next session will be Symposium on Hepatobiliary and Pancreatic Surgery, Update in Hepatobiliary and Pancreatic Surgery. May I respectfully invite the Chairperson, Professor Khong Ao, retired Professor and Head of Department of Hepatobiliary and Pancreatic Surgery, University of Medicine, Mandalay, and Professor Sai Ao Nyo U, Professor and Head of Department of Hepatobiliary and Pancreatic Surgery, University of Medicine 1, Yangon, to the stage.
Very good morning, ladies and gentlemen. Now we are start our Plenary unit.
This section in hepatobiliary and pancreatic surgery for update in hepatobiliary and surgery. So in this section, we have 3 speakers and time allowance is 1 hour. So one speaker can speak 20 minutes. So I will call upon the additional Professor Kalayara San Raja. He is from Jawaharlal Institute of Postgraduate Medical Education and Research, Puducherry from India. And Professor Kalayarasan also did a laparoscopic quiver operation as a pre-conference workshop at our department, YSH, on 22nd March. So please talk about we will talk about the minimally invasive parenchyma preserving surgery for hilar cholangiocarcinoma.
Very good morning to all. It's my great honor to be part of this wonderful meeting. I would like to thank Professor Tudomin, the chair of this conference, and Professor Soyoung for the kind invitation. And it's been wonderful to be part of this conference. So I'll be speaking on a minimally invasive parenchyma preserving surgery for the hilar cholangiocarcinoma. I think we all know the hilar cholangiocarcinoma is one of the difficult tumors to manage. And the overview of my talk would be to give the anatomy of the hilar plate, the hilar bile duct resection that can be done with or without liver resection, and the parenchyma preserving resection in the form of segment 4 and caudate lobectomy. As I mentioned, most of these patients would require major hepatectomy. However, a major hepatectomy for hilar cholangiocarcinoma can be associated with a significant morbidity, especially in patients with poor liver function. So we need to balance the radicality of the surgery with operative safety. And that has been a challenge in these tumors. However, with a better understanding of the surgical anatomy of the hepatic hilum, so we are able to now do this parenchyma preserving surgery in selected patients. So which group of patients are candidates for this? As I mentioned, you can do this parenchyma preserving surgery with just hilar bile duct resection without any liver resection, or with segment 4 with or without caudate lobectomy. So for doing hilar bile duct resection without liver resection, it should be done in low-grade hilar tumors like IP and B. There should not be vascular involvement, and the primary biliary confluence should not be involved. So these are the very, very small group of patients where you can do a hilar bile duct resection without liver resection. And you can achieve that with liver splitting or segment 4 liver resection when the tumor reaches up to the primary confluence for the adequate proximal margin. So these are the low-grade tumors. However, when you have a hilar cholangiocarcinoma, then the caudate lobectomy becomes an important part of the surgery, and you need to do at least a segment 4 and a caudate lobectomy. So that's how we decide on what type of parenchyma preserving surgery in these patients. So before we proceed further, we should understand the anatomy. So what is hilar bile duct? We all know the Glisonian sheath is thickened in certain parts of the liver and they are called as plate. The portion of the bile duct that is covered by the hilar plate, and this is the portion of the bile duct which is covered by the hilar plate, and that's called as the hilar bile duct. So that's the first important anatomical point which you need to understand when we discuss about this parenchyma preserving surgery. So once you know what is the hilar bile duct, we should next understand what is the extent of this hilar bile duct. As you can see here, it's almost 4 centimeter on the left side and 3 centimeter on the right. So this shaded portion represents the hilar bile duct. So you can see it's slightly longer in left compared to the right. Now, this hilar bile duct, how you can approach. So we divide that into level 1 and level 2. As you can see here, the solid line that indicates the level 1 of the hilar bile duct, and that can be approached without liver splitting or resection. And the dotted lines that indicates the level 2, which is usually the sectoral ducts, and then which requires a liver splitting or resection. Now, beyond this dotted line, you cannot separate the bile duct safely from the other structures of Glisonian sheath, namely the portal vein and the hepatic artery. And that's why you cannot do this hilar bile duct resection beyond that dotted line. So you have a level 1 duct which can be approached without liver splitting or resection, and the level 2 which requires either the liver splitting or resection. So depending upon the extent of the hilar bile duct to be removed, we decide on the approach of how to achieve the R0 resection. So I'll be showing a small video clips of various procedures. Now this is a patient with IP and B involving the just going up to and not crossing the primary confluence. And in this patient, so we decided to hilar bile duct resection without liver resection because we felt we could achieve an adequate margin without requiring liver resection. So the first step is dividing the lower end of the bile duct, and that is facilitated by division of the gastroduodenal artery. So that the lower end of the bile duct, you can send it for frozen. You complete the lymphadenectomy. Once the lymphadenectomy is completed, then you can see here, this is the portal vein, hepatic artery, and here you can see the anterior sectoral duct, the posterior sectoral duct, and the left hepatic duct. So that's a view from the posterior, and you can see we can actually cave into the liver. This is a low-grade tumor, intraluminal tumor, not extending beyond. So you can do this approach. You can see the anterior sectoral, posterior, and the left hepatic duct. So this patient, you can see there's a white bile in this patient. And then after division, so we generally have this, the sectoral ducts, the right anterior, right posterior, and then the left hepatic duct. So here you are able to achieve the adequate margin without requiring the liver resection. So this is one form of conservative surgery you can do in hilar tumors. But remember, this is a low-grade hilar tumor which lies within the lumen and there's no transmural involvement. But once these tumors reach up to the confluence, and those are the cases where the resection which I have shown may not give you the adequate proximal margin. And there you need to do either liver splitting or liver resection. Usually we do a segment 4B liver resection. So you can see here that's a segment 4B pedicle. And then you give ICG to demarcate the line of demarcation between the segment 4 and segment 5. So you can see the segment 4B vein, which is draining to the middle hepatic vein, that is divided. So the aim of this liver resection is to give us a better view of the hilum so that you can have much better margin. So you can see here the hilum is wide open now. So you can go well into the level 2 ducts which I have shown previously. And this gives us much better margin compared to the approach without liver splitting or a resection. So this is the after section. You can see there are multiple ducts, but as I mentioned, they all lie in the same plane because they are all bound by the hilar plate. And that is an important anatomical point which you need to understand. Even though you have multiple ducts, they all lie in the same plane. And here we have gone up to the level 2 ducts and we send all the ducts for frozen. Ensure that they are negative, because if any of the ducts, the frozen becomes positive, then you might require an additional liver resection. So traditionally, when you have this type of multiple ducts, what is described is to do a multiple anastomosis. But because of the understanding that they all lie in the same plane bound by the hilar plate, what we do is we do a septoplasty, which connects all these ducts together. And then we do as a single anastomosis instead of the multiple anastomosis, which you can see. This is a traditional way of incorporating these ducts with a different anastomosis. But what we do is we incorporate all these ducts in a single anastomosis. You make a bigger enterotomy. First, complete the posterior layer, incorporating all these ducts, and then we do the anterior layer. So that's how this procedure is performed. Now, this is for a low-grade tumor coming up to the confluence where you are just doing a hilar bile duct resection with just segment 4B resection, and the aim is to have a wider ductal margin. But once you have hilar cholangiocarcinoma, then this procedure may not be adequate because you need to remove the caudate. And so what I'll be showing next is for a hilar cholangiocarcinoma, which is going up to the secondary confluence on both the sides. This is a PTBD done on both segment 3 and right posterior sectoral duct. And you can see, again, we have used a robotic approach with the 4 robotic trocars, 2 assistant trocars. And this is initially you can see the PTBD, one on the left, one on the right. Retract the liver, do a lymphadenectomy. So that's a first step. So the lymphadenectomy starts from 8A, and then we proceed along the left border of the portal vein. The right gastric artery is divided, and then you dissect along the proper hepatic artery. This is the dissection of the HDL nodes, and you can see the caudate vessels are divided. And then we do the distal bile duct division. Again, we send it for frozen, making sure it is negative. And the lymphadenectomy is now completed. So the lymph nodes are taken en bloc. So once the lymphadenectomy is completed, we do the caudate mobilization. The caudate is completely mobilized from the left approach. You can see the camera is in the third arm. Sometimes you'll have big caudate veins, which you need to safely control by placing the bulldog clamps. And then you mark the first line of transection just to the right of the falciform after clamping the segment 4 artery. So this is the dissection done to the right of the falciform. So we use intermittent Pringle. Then you clamp the left portal vein, give ICG, then mark the right transection plane. So that is between the segment 4 and segment 5 and 8. So the liver transection is done, the superficial with cautery, and the deep transection done with Maryland. And then we are now dividing the right posterior sectoral duct. After that, we do the caudate lobectomy. So this is the junction between the right half of the caudate and the posterior sector. So once you do that, you can divide the right anterior sector. And finally, we divide the left lateral. So you can see the PTBD on the segment 3 duct. And finally, the caudate is shifted from the left to the right. This is the most challenging part of this procedure. And you complete the segment 4 transection. So the segment 4 and segment 1 has been resected. And you can see the right and left portal vein, the left hepatic artery, the right anterior and posterior branches of the hepatic artery, and the IVC here. So that's the IVC. So this is the anatomy which you see at the end of segment 4 and caudate lobectomy. Now you can see that's a segment 3 duct where you can see the PTBD from inside. That's a segment 2 duct which is being cannulated. And then you have the anterior, that is segment 5, and then the segment 8 ducts which are being cannulated. So that's segment 5 and 8, and then you have the segment 6 and segment 7 duct which are being cannulated. So you have the 6 ducts, but because now the hilar plate is excised, so you have all these ducts separately. Each sector will be lying separately. So that's a difference between what we have seen previously compared to what we are observing after caudate lobectomy and segment 1 4 resection. So you need to do a 3 anastomosis, one anastomosis incorporating the segment 6 and 7. The next anastomosis will incorporate the segment 5 and 8, and then the segment 2 and 3 in the separate anastomosis. So the reconstruction is a bit challenging compared to the major hepatectomies. But however, with the robotic platform, you can achieve the anastomosis safely. It does take time, but however, with patients, you can do this. The main advantage is the incidence of liver failure, the post-operative liver failure will come down. And that's, you can see the post-operative specimen. So to conclude, the parenchyma preserving surgery is feasible for selected patients with hilar tumors. And if you want to use a minimally invasive approach, then the robotic approach might be the a preferred method of doing this surgery. Thank you for your kind attention.
Professor Kalayasan, for your excellent talk.
Thank you.
So,
As the time is short, may I call the next speaker, Professor Ayashira Kabadi. Professor is a senior consultant, division of the hepatobiliary and pancreatic surgery, Department of Surgery, Surgery Director, and senior consultant in adult liver transplant program, National University Center for Organ Transplantation at the University Hospital. He has led several quality improvement projects in the hospital, including reducing length of stay and efficient discharge processes. He has developed clinical pathway and protocol for patients undergoing liver transplantation. He has contributed actively to the development of adult liver transplant program and donor surgery for pediatric living donor liver transplant at the NUH. He also did the perihilar cholangiocarcinoma at the workshop on 22nd March 2025. Yes, may I call Professor Devashira Kavadi for presentation.
Thank you very much. I really thank the organizing chairperson, Prof. Mo, and the organizing team, Prof. Thai, Prof. Sai, for the kind invitation. And it's been a real honor to be at this fine symposium. I have no disclosures. I had some quizzes prepared, but unfortunately I cannot run it because I'm doing it from this laptop. But what is the topic that I'm going to cover is downstaging HCC for resection as a part of updates in HCC. So what's the advantage of combining TACE with systemic therapy? And the options included the less number of TACE, shorter hospitalization, less complications, or the synergistic effect of TACE and systemic treatment. So if you look at the BCLC update, the biggest update has been the inclusion of immunotherapy in patients who were previously offered systemic treatment, and a lot more has been added in terms of immunotherapy. So what has been the game changing in advanced HCC is that if we look at unresectable HCC, their 5-year survival is only about 16%. And even if we resect, the 5-year survival is low. But with advanced HCC, if we use conversion therapy, that means what was initially unresectable to what is resectable, we are now converting to about 50% of patients to resection, and the survival also has improved. 30% to resection, and the survival is almost 50%, almost like what we see with early HCC. But there are effective downstaging options, but there is lack of guidelines and there is lack of standardized protocols, and there are diverse approaches showing promising results. So if we look at any tumor, liver tumor, now we have to think of HCC also, just like we think of pancreatic cancer as either resectable, borderline resectable, or unresectable. And so our focus is basically what is borderline resectable. Previously, they were all considered to be unresectable. So this big group was insufficient. FLR, no extrahepatic disease, multifocal unilobar or bifocal bilobar, need for vascular resection and reconstruction. The Childs-Pugh score is less than 7, and AFP is more than 1,000, and there is a VP1 to VP4 portal vein tumor thrombus. So these are the considerations we have when we talk about HCC. Tumor factors, which include vascular biliary anatomy, location, invasion, extrahepatic disease, biomarkers, patient and liver factors, and which importantly includes cirrhosis and portal hypertension, liver regeneration, and of course the oncological factors. There are established methods to increase FLR, which includes PVE, PVL, sequential TACE and portal vein embolization, total liver venous deprivation, ALPS procedure, and Y90. And we have shown in our studies that ALPS actually increases the regeneration rates, but actually the quality of regeneration is not that good. So the downstaging strategies has been described in multiple guidelines, and they commonly include TACE, TAR, systemic therapy, and SBRT. Hepatic arterial infusion chemotherapy has been used extensively in China, and the new kid in the block is histotripsy, which is ultrasound-based technology. So now, I won't go through the whole slide, but I want to just emphasize among all the treatment modalities, I mean, good to have a picture of this. You can see that there are specific roles for certain modalities. For example, a transarterial radioembolization is useful with portal vein invasion. Hepatic arterial infusion chemotherapy is also useful in patients with portal vein tumor thrombus. So each has a certain degree of response rate. Each has certain degree of downstaging to resection, and each has certain limitations. So where do we use what? We'll just go through some of the cases so that we can get an idea of how we manage. So 65-year-old gentleman with hypertension, hyperlipidemia presents with right-sided chest pain, and workup reveals a large liver mass. The AFP is high, Hep B and C are negative, and the liver function is preserved. So here is the video which shows a large tumor. I'm sorry it's played very fast, but it will play slowly. Now you can see that the tumor is very close to the cava. The left hepatic vein is very close. The left pedicle is close. The right hepatic vein is closed. So there are very limited, I mean, the options. You see the right hepatic vein, it's very close to the caudate area of the tumor. So this has very limited options. So what do we do for this patient? Is it TACE? Is it Y90? Or is it combination treatment? So in this patient, we did 2 times TACE and then Y90, and this was the response. And with this response, we can see that that largely the tumor has necrosed, and the right hepatic vein has now moved out of the way. The middle hepatic vein is still involved. There's a large tumor here with some areas of necrosis, and so eventually we said, okay, the liver function was still preserved. We then did an extended left hepatectomy. There's the anterior sectoral pedicle, and finally the posterior sector is remaining. And this patient has 2 years of disease-free interval before he got a recurrence, which was again treated. And with multiple treatments, he survived for about 7 years, which is much better than what would have happened. Neoadjuvant treatment with immunological agents improve postoperative recurrence-free survival, not yet regarded as standard of care, but promising results with immune checkpoint inhibitors. And there are 2 large trials which show now benefit with immunotherapy. So immunotherapy has a synergistic effect with TACE or arterial deprivation techniques, such as TACE or TAR causes necrosis, there's increasing T cells, the recruitment, and these immunological agents, which include TKIs, PD-1 inhibitors, PDL1 or programmed death ligand 1 inhibitor, CTLA inhibitors, or VGF antibody, they work synergistically to achieve good tumor control. And there are multiple trials going on for even resectable HCC now, and we are awaiting results for many. So the landscape is certainly changing, and in a year or two, we'll see a lot more happening in this field. So the next patient is the 59-year-old lady, again, epigastric pain for 3 days, came with a high viral load and some transaminitis, and this showed a ruptured hepatoma. So, of course, the immediate treatment, although the vitals were stable, was to achieve local control with transarterial embolization. The AFP post 6 weeks of embolization increased from 4,800 to 9,000. So, would you go in and resect such a tumor? There will be possibly peritoneal disease. There will be possibly. There is an argument that you can do a laparoscopy and then go ahead with the resection. But the other alternative we choose was to give immunotherapy. And if, as you can see, the AFP trend with immunotherapy, the AFP improved to from thousands to 95. And after that, the resection was undertaken with good long-term outcomes. So our aim is not just to operate safely, but also to give them benefit of long-term survival. And there's a next case where 69-year-old lady with hypertension, hypochondrial pain, loss of weight, Hep B and C negative, LFT was normal, AFP was borderline, other tumor markers were normal. So it looked like a HCC, which invades into the IVC and goes up to the atrium. Now here, there is a danger that the tumor embolus may go into the cause pulmonary embolism and sudden death. So in this patient, the left lateral segment and segment 4, the left side of the liver was preserved. Now what do? Do you subject her to palliative treatment or do you offer any possibility of curative intent? That was the questions that I had. And eventually we did a thorough workup, which included triphasic livers, PET scans, because we want to be sure there is no metastatic disease. For HCC, we use dual tracer PET scan. We did a cardiac assessment with coronary angiogram and echocardiogram to assess both ventricular functions, and then did a cardiopulmonary bypass. We ready the bypass. We did a full transection anterior approach. Then after we reached the IVC, then total vascular exclusion of the left lobe, then opened the cava and the atrium on a bypass, and then took out the tumor. And this patient also survived about 2.5 years disease-free, after which he got recurrence in the lung. Now, finally, there is this 70-year-old gentleman with no medical history, dyspnea and reduced effort tolerance, transaminitis, very high viral load, and this was the CT scan, which showed a very large right tumor, which was stuck to the diaphragm, and this patient also had presented with a MI, non-STEMI, and so the cardiologist said this big tumor, palliative treatment cannot do CABG. And we said, if we give treatment to the tumor, will you do a bypass? And they agreed. So we did a TACE first, then the patient had a bypass, then, of course, second round of TACE, and after that, we then had a tumor which was largely having some necrosis, and this was laparoscopic liver resection, including resection of the diaphragm. And again, for large tumors, we do an anterior approach. Of course, the initial steps of the gallbladder dissection, I will skip. But essentially, in all laparoscopic liver resections, I tend to keep the cystic artery long because I like to have the option of doing a cholangiogram if ICG is not available. Of course, with ICG, you can do a lot of things. You can look for bile leaks, you can look for transaction lines, you can look for smaller tumors. But in absence of that, keep the cystic duct long, and then you can put a cannula in and do a cholangiogram. So, of course, this is a standardized mobilization of the falciform. Some of the adhesions to the diaphragm, we took it down. And this is the hilar dissection. And the vessels were slung. Again, some of the adhesions we took down, but it is impossible to mobilize the right lobe of the liver completely because of the big tumor, heavy tumor, and stuck to the diaphragm. Although there is necrosis. Again, we need to ensure that try hard not to manipulate the tumor to prevent spillage of a rupture of tumor and spillage of cells. So again, this is the hilar dissection. There was a lot of adhesions in the hilar area as well. Again, all these treatments, TACE, TARE, systemic treatments, they can tend to cause adhesions and can make the surgery more difficult. Again, this the anterior approach, progressive parenchymal transection. I use a 3D equipment for this procedure because the 3D gives you a nice depth, and with the depth, you don't need to sling every vessel before you clip it. It is easy to judge which pedicles need a 5 mm clip, which need a 10 mm clip. It is easier to do it with a 3D. Unfortunately, when I transcribed this 3D into a 2D format, it lost some of its resolution. But this is the parenchymal transection done in a standard manner. And we keep cutting till we reach the hilum, then divide the hilar vessels. The initial, it was done in selective vascular clamping. I didn't want to cut the vessels and straight up in the initial phase. And this is a right hepatic vein which is slung and stapled. There are clips here. You have to ensure that when the stapler goes, the clips are taken care of so that you don't accidentally misfire the stapler. And finally, the right lobe of the liver is separated from the cava. At the back, there are we have to take care of the the adrenal vein, and you have to stitch the adrenal vein. And this is the adrenal being taken off, and then I usually put a stitch over there. And then this is the diaphragm which is pulled and then slung it and resected this part of the diaphragm using a stapler. You ask the anesthetist to drop the lungs during this procedure. And then if, lower down also, the diaphragm was quite badly stuck. And there the diaphragm was opened, and we then took out a small segment of the diaphragm and then suture closed the diaphragm. So the long and short is, even for big tumors, laparoscopic hepatectomy can be done. Of course, you start small and then progressively move to bigger and bigger cases. Most of this blood is from the liver. It is from the adhesions. But overall, the blood loss was less than 400 mils. And once the liver is bagged, you need to ensure that the remnant liver is re-anchored and make sure the hemostasis is good. So with that, I would like to conclude my presentation with some key takeaways. In the current scenario, think combination. Multimodality treatment offers best shot at resection. TACE first is still the backbone, especially with the newer immunological agents. TARE for the tough tumors. HAIC is also a powerful tool in PV thrombus. IO really works well. Atezolizumab, durvalumab enable downstaging in advanced cases. SBRT I use selectively to downstage patients with portal vein tumor thrombus for either resection and rarely in transplant. And choose wisely, which includes patient status, liver function, and anatomy to dictate success. And resection is the goal. Cure over control always. With that, I'd like to thank you for your attention and also invite you to the ASEAN Laparoscopic HPB conference in 2025. And this is my most important slide, the IHPBA in 2026 in Singapore. Thank you very much.
Thank you very much. Thank you very much, Professor Shida, for your informative and very excellent presentation. May I invite question from the audience? If any question, no question, we have to.
Thank you.
The next speaker is Mr. Myint from Chulre Hospital, Ho Chi Minh City. And he is a head of liver transplantation unit of liver tumor department, Chulre Hospital. And his field of interest is HPV diseases and liver transplantation and cholelithiasis. Please, Professor Myint, please present your talk.
Good morning, all professor and colleagues. My name is Myint, This is my first time and very great honor to be in Myanmar and be here in Yangon to present our study of my group, Children's Hospital, the result of the laparoscopic hepatectomy to treat the left side of hepatolithiasis. So, as we all know, that hepatolithiasis is a common disease in the Asia Pacific country. Before, in my country, CBD stone exploration surgery and combined with the lithotripsy were mostly used to treat the hepatolithiasis, but it has very high recurrence rate. With innovation of the ERCP and BTBD, stone extraction is no longer the favorite treatment. Instead of that, in case of the single lobe hepatolithiasis, hepatectomy is better option and can minimize the recurrence rate. Laparoscopic hepatectomy is difficult procedure, require the experienced SBP surgeon, but it's widely adapted as a treatment for the hepatic disease, mostly in the hepatic tumor like HCC or CCC, but lap hepatectomy for hepatolithiasis has some different difficulties comparing for HCC, and actually not many centers in my country has used this technique. That's why we do this research to demonstrate the possibility and the feasibility of this technique. So there are several studies, mostly from China, already demonstrate the technique and prove its safety and effectiveness. This paper was published in Journal of Surgery in 2017 from Nanchang University, China. Another study from Chile published in 2012 show anatomic liver resection is an effective treatment. This third study in 2017, also from the China, show comparing to open hepatectomy, laparoscopic hepatectomy has optimal outcome. So to implement this technique, we make the case study report in my hospital from the February 2023 until February 2025. On the patient with the left hepatic duct stone, with or without left biliary duct stricture and with or without CBD stone. We will perform left hepatectomy or left lateral sectionectomy depend on the location of the stone and the stricture of the bile duct. So here are some CT scan of the patient. You can see the very dilated left hepatic duct and intrahepatic duct stone on the left side. And this patient also has a combined CBD stone. So the right biliary tract is also dilated. This patient has a atrophy of the left liver. You can see that the left biliary duct is dilated and it's formed a sac of the bile and stone. This patient has left bile duct stricture and very dilated bile duct. And this patient is similar. But in this patient, you can clearly see the stricture site on the right side of the right round ligament. So the indication of this patient should be the left hepatectomy. So I will show you some video of our operation. So with the experience we already have from the open surgery, there are some advantages we can apply in the lap hepatectomy for hepatolithiasis. So in case of this patient with left lobe atrophy, we don't need to do Takasaki maneuver because there's always have clear resection line, two different kind of liver. So just keep following with that. But we should remember that in this case, the left bile duct usually dilates and have an inflammatory adhesion to the middle hepatic vein. So we should carefully dissect it. If we make major injury in the middle hepatic vein, it will take us more time to control the bleeding. So it's very close to the middle hepatic vein. So in case without the left lobe atrophy, so we have to perform the Takasaki clamping to isolate the left portal pedicle. But as I mentioned in this patient of the hepatolithiasis, the left bile duct is very dilated, so it's usually very large. it's difficult to make the fully Takasaki maneuver. If possible, you should dissect the posterior to better isolate the left portal pedicle, or you can only partial Takasaki clamping. Now we prefer the partial clamping because the bile duct is dilated, but the left portal vein and the left hepatic arteries are not corresponding dilated. Sorry. And for parenchyma dissection, we mobilize the left liver by dissecting the round ligament and falciform ligament until the left triangle. We always apply the Pringle maneuver to minimize the bleeding. We prefer the ligature because it has better hemostasis, and we use it like Kelly to break the liver parenchyma before coagulate the small vessel. Then clip or hemlock the lateral branch of the middle hepatic vein. For the left hepatic vein, we can choose either stapler or hemlock depending on its size. But most of the case, we use endo-GI. For this case, we use the hemlock. This is the left hepatic vein. So this is a different from the hepatectomy for the HCC. For the hepatolithiasis, for the left portal pedicle, so we dissect the left bile duct separately and cut it first to remove any remnant stone. You can see we remove the stone here. Yes. And check the left stricture side, the bifurcation of the right bile duct, then close the left bile duct with Prolen 40. For the portal vein and hepatic artery, we also use stapler. So unfortunately, nowadays we don't have a cholangioscope in my hospital. So in all the cases, we will do the CBD exploration. Insert the T-tube, usually the 16 to 20 French, take the cholangiogram, then maintain the T-tube after operation. You can see it's the left duct stump, and the CBD exploration. So we're closing the left bile duct with Prolen. Insert the T-tube. Cholangiogram. So these are some picture of our specimen. You can see in the left picture is a stricture side of the bile duct, and on the right picture, so you see the stone is filling in the intrahepatic duct. Same as this case, the bile duct is dilated and is formed like a sac alongside with a resection line. So, and you see, it's very challenging to dissect the bile duct. It's the long one alongside with the middle hepatic vein. So from our study since 2023 until February 2025, we had 27 cases. The mean age is 52, minimum is 32, and maximum is 76. The ratio male-female is 1:2. The mean BMI is 20.4. 11% patients have diabetes and 7% have cardiovascular disease. The main symptoms of the patient is abdominal pain with 96% of patients, following by jaundice and fever with 55 and 11%. So the location of stone, we have 19 cases of left lobe, 8 cases of the left lateral lobe. So we perform respectively 19 cases of left hepatectomy and 8 cases of the left lateral sectionectomy. More than half of our patients, 15 cases, had combined CBD stone. Only 3 cases, 11%, has a previous operation history. So we need more time to dissect the adhesion. The operation time is 173 minutes. Blood loss is 130 milliliters. Actually, in our hospital, we don't weigh the goals using the operation, so the blood loss may vary a bit more. Until now, we didn't have any bleeding complication, and in any case need to be reoperated. Post-op hospital stay is 5.8 days. 2 cases have minor complication. One is small fluid collection, like you can see in the CT scan, but we don't need any further treatment. And 1 case of the SSI surgical site infection, we treat effectively with a localized treatment. So, like I mentioned, we don't have the intraoperative cholangioscope, so we only take the cholangiogram to check the remnant stone. So sometimes it's really isn't effective. We have 2 cases of the remnant stone, one in the CBD and one in the right posterior duct. So therefore, we have to wait for 1 month after the operation, then send this patient to another hospital, the Trung Vương hospital next to us, to perform the lithotripsy. So it's inconvenient for patient, but we don't have any other choice. Both are successful. And we have 1 case of the biolic at the stump of the left hepatic duct. We found it the PO3 and managed it by the ERCP sphincterotomy. We don't need the stenting because we only have the T-tube branch. So with a few minutes left, I will show the technique we do to intraoperative lithotripsy. So this is the instrument equipment we is presented by the Dr. Lê Nguyên Khôi in Trung Vương Hospital in Ho Chi Minh City. And now is many centers in my country follow this technique. So we hanging the 2 border of the CPD, and then we insert this canal. This will help the water doesn't fill in the patient abdomen, and we can easily perform the lithotripsy. You can see that it's all the water will come into this. Until now, this technique is still applied in the case the patient had a hepatolithiasis in the both side of liver, because it's in the both side of liver we couldn't resect. So to conclusion, for short outcome, laparoscopic hepatectomy for the left side hepatolithiasis show it is safe and effective treatment. We need intraoperative cholangioscope to have a better outcome, and furthermore study need to continue for the long-term outcome of this technique or apply in the left hepatectomy for the right side of the hepatolithiasis. So thank you for your attention. Hope you have a successful conference. Thank you.
Thank you, Professor Myint, for your interesting presentations. So, any questions from the floor? If no question, thank you, Professor.
Yes, thank you.